3.
Welcome to the Rocky Mountain MS Center's special webinar series during the time of COVID-19. Today, July 1st, we will be giving an update on COVID-19 and MS. This presentation features Dr. Enrique Alvarez. Dr. Alvarez is the Clinic Director at the Rocky Mountain MS Center at the University of Colorado. He is a graduate of the Medical Scientist Training Program at the University of Colorado, Denver, and completed his neurology residency and neuroimmunology fellowship at Washington University in St. Louis. He joined the Rocky Mountain MS Center at University of Colorado in 2013. If you missed something on a slide, we will be archiving this webinar on our website, mscenter.org, so that you can replay it at any time. We'll reserve some time at the end to answer questions from the audience. You can submit questions at any time by typing them into the chat window on your screen. We will answer as many questions as time allows. Today's presentation is for informational purposes only. Please note, we will only be answering questions relating to MS in this webinar. If you have general COVID-19 questions, please visit the CDC website. And all decisions regarding MS treatment and medications should be discussed with your neurologist. With that, we'll turn it over to Dr. Alvarez.
Thank you, Kelsey. It's great to be doing these again, and I hope they continue to be informative. It looks like we have almost 100 people listening live, so it sounds like they've been beneficial to some people. So thanks again. Let's start looking at what we'll talk about. We'll talk a little bit about numbers. We'll talk a little bit about sort of second waves and issues regarding that, reopening and add in reclosing now for certain things. We'll try and spend a little bit more time than we have in the past on risk factors. We got some new data that I think will be very informative as to the effect of MS drugs and other risk factors associated with that. We'll talk a little bit again about testing and vaccines, and we'll talk a little bit about treatment of COVID with some new data that's coming out on remdesivir and the steroid dexamethasone. So with that, let's kind of talk and review a little bit. It seems like we've always been now in the COVID era, but we got to remember that it's a very new virus. The first report of it came out on December 31st. The first death in China was announced sort of in January 11th. So we're kind of talking about less than 6 months that we've really kind of been dealing with this virus. It was in February where we started getting the first cases in the U.S. We're talking about 1 million cases worldwide by April 2nd. As we start to kind of talk about April 10th for 100,000 deaths globally, we hit that mark on May 28th. And as we look at things today and where we stand, we've already had about 500,000 deaths globally. That number comes out really fast, but man, that is scary to be thinking about as we start to kind of see some of these numbers kind of go up. So what have the numbers done in different parts of the world? And I think this is the part that we have to understand, that different parts of the world have been very different. So these are the number of new cases of COVID on a day-to-day basis for 4 different countries. You can see in the United States where we had a lot of cases up front, things were starting to get better, and then numbers starting to go back up. And we're starting to get more cases now than we ever did at the beginning. This is a concern, and we'll see a little bit later that this is not the same in all states. But I think it's important to kind of recognize this when you start to think about potentially maybe travel plans, where you're at, where people coming in to see you are from, and things like that. There are certain countries that...
Dr. Alvarez, could you just speak up a little bit more?
Sure, yes. No, I appreciate it. Thanks.
Thank you.
And so as we look at certain other countries, Brazil, India, Russia fell into this category of countries where COVID has hit a little bit later, and you're starting to kind of see the numbers rise in those countries now. Spain, Italy, most of Europe really started much earlier than we did here in the United States, and their numbers have gone down and way down compared to where we're at now. So I think they learned some of their lessons, and maybe some of the rest of us can appreciate that and take advantage of that. And we'll be talking about some of this data that we learn about a little bit later. Is that a little bit better, Kelsey?
Yes, thank you.
All right, perfect. So let's break it down by states a little bit. So we can see, and these are all fairly pretty much on the same timeline. The vertical axis you can see is very different, but just it helps highlight some of the differences. Colorado got hit early compared to most of the states listed here, but our numbers are starting to kind of go down, and there's an inkling maybe of some over the last week or two of numbers starting to kind of maybe trend upwards again. You see a lot of variability. You see kind of those little kind of spikes, and a lot of that has to do with weekends and how numbers are averaged and things like this. And so that makes some of these numbers tricky, but I think you can clearly see the trends from them. New York, you can see, kind of fits that European pattern a little bit, got hit early, and then the numbers are really going down, versus other states like Texas and Arizona are getting swamped out. Florida is included in that. California maybe starting a little bit later, but the numbers are really starting to go up high. So you can see that there's patterns changes in different states. If we look at all of these for all the different states, these are the states looking at it from much more individually. These come from a different website. So these are coming in from the New York Times. The data that I showed you before comes from the Johns Hopkins COVID website. The web links are listed below. And these are sometimes just fun to kind of go through if you're interested and kind of see where the numbers are going, where they're headed, how things are changing, and those kinds of things. You can see these are all the states, and you can see most states are listed here where the numbers are going up. But I think it's important to recognize that, you know, just because they're going up doesn't mean much, in the sense that when you look at that first state in California, numbers were relatively low, and then they've really kind of jumped up. That spike is really noticeable for Texas and Florida. If you skip to Arizona, that's another state that looks particularly scary. As opposed to kind of the rise that you see in Colorado, where it's been kind of a very gradual, and the numbers are still much below sort of where our peaks had been. You won't see states here that include New York, New Jersey. So if the numbers were really high, it's going to be really hard to kind of get back up to those levels. And so there's a little bit of bias as to where you've been in order to kind of see where the trends are recently as far as some of these states go. I think for us sitting here in Colorado, the challenge is that as we look at the states around us, that many of those states are listed here and look particularly bad. As we start to look at Arizona as making a lot of the news, having personal conversations with docs that know docs there or directly with the docs there. Some of the hospitals are simply lining up patients in the hallways, having to build tents outside their hospitals to accommodate the COVID patients. We never got to that point here in Colorado, but it looks particularly bad, and I'll show the example of Arizona here in a little bit, coming up in a few slides. Idaho, Utah, a lot of these states are particularly bad. So, so I think the concern is that, this stuff could potentially be starting to hit Colorado anytime soon. And I think in light of kind of the 4th of July weekend, we need to be particularly careful as we start to plan for that, especially if you have maybe out-of-state companies, people coming to visit you and friends. We can break it out even further. This is still data from the New York Times, where it breaks it up by county. And you can see that light yellows and oranges aren't necessarily too bad. They're not great. They just mean that the numbers are fairly stable. You can see that the dark reds are where the numbers are really kind of going up fast. Blue is good. That means the numbers are going down. So in order to go down, you have to have been pretty high. And so you're starting to kind of see smatterings a little bit in the New York area and things like that, where things were starting to kind of cool down. Front Range in Colorado is particularly hard hit, and so that's coming down. But it's important to recognize when you're looking at this that these maps change a lot. So if we look at this map last week, this was really red looking at the Southeast. All those states were, and that wasn't sort of a political pun, I apologize for that, but basically a lot of those states were dark red because those levels, some of those states and counties have leveled off some. You see that some of them are starting to turn orange or yellow. California is starting to kind of go up in some of the major metropolitan areas, and things kind of maybe remaining a little bit more stable. But you can see that the spikes in some of the areas where things have been particularly hard hit for some of the states I mentioned earlier are really concentrated in some of the large cities. So in Arizona, for example, it's areas around Phoenix. In Texas, Houston has been particularly hard hit. And again, some of the larger cities in Florida. This has been particularly noted after holiday weekend, such as Memorial Day weekend, where you had a lot of people celebrating and going to nightclubs and bars and things like this. And so it kind of speaks a little bit to the transmission of things. And that's taught us some lessons as to how the virus is transmitted, and really kind of requiring close contact with other people. Meaning this is a virus that even though people have made notice that it can be spread with aerosols, meaning little tiny particles that spread easily from person to person, the vast majority of the transmissions tends to be bigger droplets, which means that you really need to have close contact with people. Passing somebody down the street or things like this won't be the way to transmit the virus, but it's really sort of an issue around sharing a glass, touching doorknobs and then touching your face, and things like that. So outdoor contact tends to be a little bit less, and you see less transmission that way. So I think those are things that we can learn from a little bit as time even goes by. All right, so let's look at our state a little bit and hospital resources. We'd like to kind of show this data. This is a little bit showing data to the left of marked as today, July 1st, and kind of predictive a little bit to the right as the time goes on. We've shown kind of differences as to what modeling shows and where we actually do. So these numbers, if you remember back in March and April, were showing spikes where the number of beds in Colorado weren't going to be enough to accommodate all the patients. And we can see that we did fairly well. The top line is the number of hospital beds. The bottom line is the ICU beds in green. The dashed line on top is the number of hospital beds actually used, and the darker line dashed on the bottom is the number of ICU beds. So we end up getting to a point where we're using about half the ICU beds in the state. And we can see that at least for the foreseeable future, according to this model, nowadays that things are slowing down with maybe potentially a concern of kind of raising levels. Let's compare that to Arizona, where we can see sort of this new spike that's happened, higher than the first spike. And you can see that that bottom line is dangerously close to the line where the ICU beds. That's for the entire state, and we already saw that the breakdown from county to county is very different, so that in certain areas, the number of ICU beds has been outstripped by the number of patients attending some of those hospitals. And then, if they're safe for transport, you can maybe move those patients to other hospitals. But again, that's starting to use up even more of the resources and things like that. So this is why we start to get nervous in some states, is that we are outstripping the capacity of the healthcare system of taking care of some of these patients. So this is the bad and hopefully what we can avoid. So what worked really well? What worked was distancing. This is what we call sometimes a spaghetti graph. It looks like a bunch of spaghetti. It highlights all the states and sort of the range of the states. The bars to the top are you can imagine a lot more of the rural type states, Midwestern states. I think the top line's like Wyoming, the next two lines are the Dakotas. Having come down here from North Dakota, I can tell you that it's a little bit funny to not think about North Dakota as socially distanced. because I think just living in those states makes you somewhat socially distanced compared to living in Denver or things like this. So as you look at it, you can see that we're pretty good. The blue line is Colorado. We socially distanced a little bit better than the numbers in the United States, kind of on average. And now things are kind of been opening up, and you can see again the modeling issues is that it's predicting that things are going to continue to open. We know that that's not necessarily going to be the case. As we look at it in Colorado, yesterday we had nightclubs and bars being closed, and so there's going to be a little bit more socially distancing potentially happening. I think that the other issue with looking at socially distancing is that this looks at things that sometimes may not reflect exactly how well we can prevent a disease. So they're proxies, they're kind of things that maybe kind of go hand in hand. It looks at how much traffic is in the roads and things like this, but it doesn't look at how much mask use is occurring. It doesn't look at specifically bars or nightclubs where people maybe get a lot closer to each other and probably transmit the virus a lot more versus kind of restaurants or maybe outdoor restaurants or takeaway restaurants, because you're going to use the same amount of gas to go to a takeaway restaurant and take it home than if you eat at the restaurant. So these are guesstimates. They don't necessarily really represent how socially distanced we are, but it's some useful data to kind of say during those times where we did this, things work. As things are opening up, we're starting to see an increase in numbers of COVID. I think as we're learning, we're starting to get a sense that there's certain things that maybe we can be a little bit more specific about, and so maybe it's less at restaurants and more nightclubs that's affected. So we can be a little bit more targeted as opposed to closing everything else down. Just to kind of make some comments about this, I think there's a number of questions around, can I go to the hairdresser? Can I do this? Can I do that? It all has to do with how careful those establishments are. I can tell you I've been to my hairdresser. I got my hair cut, and as soon as they were done cutting my hair, they were spraying down the chair with disinfectant, sterilizing everything and things like this. I felt really comfortable doing some of those things. If you're having to go to a nightclub where you're standing 2 feet away from somebody, and I haven't probably guessed that there's probably a lot of nightlife type things occurring where people are wearing masks, that I would feel that safe doing that. So I think you have to understand a little bit who you're meeting with. How safe are they? Have they been around a lot of other people themselves? Have they been pretty good about socially distancing? And so that's where it gets hard to generalize and answer some of these questions. And I think you have to kind of look at the individual circumstances to answer those questions. So I'm going to harp on, I did this a little bit at our last update on masks. I showed this meme. It's really to highlight, I think, something that is proving very beneficial. I will disagree wholeheartedly with our current leadership, who is making a comment that, wearing masks is a matter of personal choice. I think that might be the case. I mean, it's your choice to do so or not. There are certain states and areas, in the Denver metro area, for example, it is a law that to go into stores and things like this, you must wear a mask. You may have the choice of going into certain establishments or not. So, I mean, this is kind of the issue around the personal choice part of things. But it's more of a courtesy to others, and it's less about you, and I think that's the big concern. So this issue of kind of the pant test or maybe the urine test, I think becomes really important. I'll let people read it on their own. But if you are not wearing a mask, I think it's really hard to make the argument that you're being considerate of others. And I think that, this is not one of those things that should be left to individuals to some extent. I think this is one of those things that if you're in, especially grocery stores or other things like this, where people need to go into, that mask should be wholeheartedly made a requirement to be. All right, so how much of an effect might wearing masks do? So this actually got incorporated into this modeling stuff, and again, the modeling comes in from this organization called IHME. And it's a little bit hard to see, but the link is there in dark blue at the bottom. You can see that for Colorado, starting as of today, if you were going to model things as they stand, the number of cases would kind of probably stay pretty steady. If masks are required, you would see actually a fairly decent drop in the use of masks. It is impressive a little bit how much or how little in certain areas this is followed. If you go to the grocery store in Denver, at least around where I go, here around campus, you will find that most everybody's wearing a mask. I've been hearing that if you're up in the mountains or kind of smaller communities, that very few people are wearing masks. And so you can see here on the modeling how much of an effect we think that wearing those masks simply by itself, allowing you to do pretty much everything else, would have on this. So I'm sorry that I keep harping on this, but I think it's one of those things that is a simple thing, as much of a pain in the tuchus as it might be to wear a mask, how important it can really be in this current pandemic. All right, so so infections is one thing. We can look at hospitalizations, and we can see these really nice trends coming down for Colorado around COVID-19 hospitalizations. That blue line is the number of patients currently hospitalized, and we're pretty much hitting bottom lows for this. Maybe gone up a little bit in the last week, but compared to where we were, where we had about 900 patients at one time hospitalized at any given point, we're down to about 144. So in that regard, we're doing really pretty well. If we look at ICU beds, that bottom line tells us how many ventilators are actually being used for COVID patients. And this is overall, so I apologize for that, not necessarily just for COVID, but it kind of gives you an idea that if they're not being used, they're available and they could be used by COVID patients. This data comes from the Colorado Public Health website and gives really good information about sort of the number of cases, hospitalizations, and things like that in the state. Another very useful part of this website, I didn't necessarily want to put it here, but it allows for contact tracing. So what is that? That is when people present with a case, the State Department's going around and trying to figure out whether that person was affected by COVID and trying to understand if, how they got contacted, if who else might be at risk so that they can test those people, things like that. And you can go to this website and find out exactly where all the outbreaks are, if they're resolved, if they're still active, if they're happening at a certain store, meat packing plant, things like this, where most of the cases in Colorado early, the big outbreaks were occurring. All right, so if we look at ICU beds, we got to talk about deaths. And again, really good numbers in Colorado coming down finally over the last several weeks. Numbers have been really, really stable. We've not quite yet had a day with 0 deaths, so we're getting close to that, and so very excited about that day when it does come. All right, so if we look at these bad outcomes, the other thing we can start to learn from this data a little bit is what contributes and who's dying. That's going to be a big one as far as some of the questions that I know will come up a little bit later. So if we split this out by age, and some of these slides people have seen if they've been listening to these in the past, you can see from here that age is a huge, huge factor in how people do with COVID. As you look at most of these age groups, even into your 30s and 40s, very few people are getting hospitalized in the light blue. As you start to kind of get into your 50s, you see a little bit of a capping there of deaths. And then you start to kind of really see that number grow as you get into a little bit the 60s, but particularly the 70s, where maybe 20% of patients who become infected might die, and almost 40% by the time you look at patients that are 80 and older. So age has a huge effect. What are some of the other things? This is not looking at MS patients specifically. We touched on this at the last seminar as well, but we can see that heart disease is a big one. We can look at diabetes, chronic respiratory disease. This is probably a little bit less asthma and more things like COPD and things like that that are probably really confirming that. And so the death rate kind of indicates that, for patients who die, how many have cardiovascular disease. And cardiovascular disease really is talking more about heart failure and that kind of stuff. These numbers come from two different sources on the left and on the right, but you can see that the risk factors between one and the other one are very similar. The more of these that you have, if you look at the bottom of the right column, tell you that it's not just having one of them, but if you have three of them, that the numbers almost double compared to just having one or maybe two of these things. So again, the healthier you are kind of otherwise, the less the chance of dying from COVID. We talked about age and those kinds of things. All right, so let's talk a little bit more about MS patients specifically. We have mentioned in the past that we're touching base with a lot of our colleagues around. Risks do not appear to be higher in MS patients. I think that's still very much kind of bearing out. The outcomes question appear to be the same for other patients, even if treated with, for MS patients as for other patients, even if they're treated with immunosuppressive medications. There's a little bit of controversy around this, and I'll show some data that kind of helps explain that. So to kind of get into a lot of data, we'll do this here next. This is a paper that just came out, 4 days ago. It is looking at a large data set from France that was published in JAMA Neurology. Really nice paper looking at comorbidities and drug use, not illegal drug use, but MS, disease-modifying therapies in MS. The top part and bottom part are very similar graphs, really, in the sense they're just kind of looking at things in a little bit different way. So in the top graph, if you look at death, you will see a lot of gray built in, and if you look at the legend on the kind of the right top side, you'll see that that's actually patients that are on no treatment. So almost 3/4, if not higher, of the patients who died were not even being treated with a disease-modifying therapy. As the severity kind of goes down for the outcomes for patients with COVID, you can see sort of the breakdown by different drugs. Part of this you would have to know a little bit about sort of how much each of these drugs are being used in the places that were reporting into this database. And again, this was mostly French centers that published in this group. In the bottom part, you can see it split out by drug and then looking at the severity. So if you look to the far left on the bottom, you'll see that for no treatment, that a lot of people on no treatment actually had more of the dark blue, meaning they had worse outcomes, and the darkest of blue is death. Rituximab looks pretty dark. Ocrelizumab looks kind of dark, so there's a little bit of concern for this. But the nice thing about this paper is they explore this further, because guess what? The patients on rituximab and ocrelizumab tend to be older patients, and we already talked about age being a little bit worse of an outcome. All right, so what are the other things that contribute to this? Well, in this data set, being older also makes it for a worse outcome. You can see that those that are hospitalized or died were older, about almost 15 years older than the patients who were not hospitalized. EDSS is a disability, is expanded disability status scale, so it's how disabled are you. If you look at the scale, 10 is dead, 6 is using a cane, 1 is starting to, 2 is really kind of having some symptoms that are noticeable that somebody could look at and measure, and it kind of builds up from that. And you can see that on average, the disability goes from about a 2 to a 6. So the difference between not hospitalized and hospitalized, meaning those patients that are being hospitalized or dying on average pretty much were using at least a cane, versus the vast majority of those that were not hospitalized were not that disabled. All right, so let's break this down a little bit further, and we can actually start putting numbers to this. So if you look at that top row in this group, you will see that age per 10 years has the OR's odds ratio of 2.49. That means that for every 10 years, there's a 2.5-fold higher risk of having a bad outcome. That is, being hospitalized or dying from the disease. If you are a man, your chances of being hospitalized or dying are 2.1-fold higher. If you look at cardiac comorbidities, numbers are almost 6 times higher. Pulmonary issues, 3.5. Diabetes, 5.36. Smoking, maybe a little bit preventative. Okay, so what you see there is the bar crosses that midline, that straight up line. So that means that there's really no difference or no effect just from smoking itself. Being obese is worse. It increases it by almost 3-fold. A progressive course jumps up a lot. If you have these breakdowns by disability level, you can see that. Curiously, then, you look at the treatments. So being on treatment appears to be protective. If you're on, if you go to the bottom line, if you go to alemtuzumab, cladribine, fingolimod, ocrelizumab, or rituximab, maybe not as protective as is some of the orals in that kind of next up row, and even less protective. If you're on interferon and Copaxone, maybe really protective. Again, we talked about some of the patients on those drugs having more disability, being older, and things like this. So we can adjust this. This is looking at each one of these things individually. If we put all of them together and do what they call a multivariate analysis, you can say and kind of isolate the effect of each one of these risk factors. And if you do that, what jumps out is that age increases the risk of the bad outcomes. Being male crosses that midline, so statistically not much of a difference. Being obese increases it some, almost 3-fold. Heart issues increases it some, maybe crosses that midline, so not statistically. As you look at disability kind of going up, you can see the rapid increase in this. By the time you look at the drugs and you account for all these other things, being on a disease-modifying therapy, any of the treatments for COVID, had no effect on whether that patient was hospitalized or died from COVID. This was a significant group. This was almost 350 patients. So it provides a lot of data for us to kind of say, where do I fit into this scheme, and how risky is it for me to interact with people or do other things? If you're very disabled, older, male, have heart failure, COPD, those kinds of things, I'd probably protect a lot more and kind of think about trying to stay and limit my interactions with other people a lot more. All right, let's turn to the U.S. data. Sorry, this print I'm just realizing is a little bit on the smaller side. But in this data set, it's almost now as large as that French data set, so 330 cases. There's also a few smattering of cases with other conditions, including NMO or the HAB11. I like this data set compared to a lot of the other European registries because a lot of these have lab confirmation to it, because unlike in Europe, where we were affected a little bit later, we had a lot more testing available to us than the Europeans did when they were dealing with their pandemic. So out of these 330 patients, we can see that there was 20 deaths, with nearly 200 of them now having recovered, 12 of them whose symptoms never even developed. So, I mean, it's impressive how many patients are still kind of asymptomatic with this. All right, so what's different about these 20 patients compared to the other patients that are still alive? I just realized that when I was pulling this data over the 5 minutes, it looks like there was another death reported, so they went up to 21. But you can see that the patients who are dying are older. So if you go to the age column, the average age of the patient that died was 63.2 versus those that are alive is 47.7. So almost 15 years older. Because they're older, they're going to have disease longer. The ratio of men to women is pretty typical for those alive. So it's kind of like a 3-to-1 ratio, which is kind of what we tend to see nowadays. But it's almost a 50-50 chance of being female for those that die, meaning a lot more of the men are also dying, so that we can see in the U.S. Most of the confirmed deaths are MS. There's 2 in the NMO group. The type of MS, again, probably matters. You're seeing a lot more of a jump in secondary progressive, a little bit higher in primary progressive. So whereas alive for primary progressive is 5.5%, it is 17.6% in those that are dead. Again, that, and similarly in the secondary progressive. And again, that goes probably to level of disability associated with that. When you start to look at that and the ambulatory status, non-ambulatory, meaning you can't walk, 60% for those that are dead, but as compared to only 10 if you were still alive. When you look at the other things, treatments here, for example, that gets really small font, so I apologize for that. But if you look at rituximab, there was 1 death on rituximab, which is a little bit under 5%, but it's 7% for those that are still alive. Even with ocrelizumab, that number drops from almost 30% to about 14% between live and deceased, meaning that some of these, the chances of dying when you're on these drugs is less than those doing well. And again, that gets influenced a lot by the age and level of disability and things like this. When we look at comorbidities, again, we see for the comorbidities that are associated that we described earlier are the same things that we're seeing in the U.S. So we have now data from French groups, from the U.S. group, and we've talked about some of the other data that maybe wasn't published, but coming in from the Italian groups, the Spanish groups, and things like this, where it doesn't appear that the numbers of people with MS are that different versus those who don't have MS, that being on treatment doesn't have much of an effect on the outcomes of COVID. Some of that is a little bit different when we look at the Swedish data. So this is coming in from Sweden. Sweden uses a lot of rituximab. You can see that about 50% of their patients, 40%, so about 50% of their patients on rituximab, 50% of their patients with COVID were on rituximab. And as you get into the ICU, it goes up to about 75. The issue a little bit that I have with this data is that we see kind of a similar increased trend up on patients on natalizumab. And natalizumab, the immune system in the lungs, natalizumab being Tysabri, by the way, that the immune system around the lungs, the bloodstream, all that stuff is pretty much unchanged. So I can't imagine where that would be that different in these patients compared to patients not on treatment. And the fact that the numbers are going up, to me, suggests a little bit what the authors point out in a lot of words, is to kind of say that people on these drugs are probably getting reported to their database more. And there's been some suggestions, again, that maybe patients in Sweden who are on these anti-CD20 treatments might be getting COVID a little bit more, might be getting hospitalized a little bit more. The number of deaths is really fairly low there, and so they have not seen that there's any particular difference at that point, however. So I think it's important to kind of keep in mind some of these things. And again, just because the data fluctuates some, has probably more to do with the small numbers of cases, the variability in how things have handled everywhere else. Sweden has not particularly socially distanced much or things like this. And even with this, if you look at these number of cases with COVID, you can see that they're still describing less than 100 patients for their entire country, versus some of these other databases in France, in the U.S. have over 300 cases. So I'm going to trust that data more than I'm going to trust this data, and just kind of say that I'm not too concerned about any of these drugs making outcomes on MS worse. And that's reflected a little bit on our guidelines to kind of continue treatment as you would expect. Let's get a little bit theoretical on things and talk about the disease maybe occurring as two different types of diseases. One is the virus disease, and the second one is sort of our body's response to the disease. And we can see towards the end that there might be some benefits in kind of controlling the immune system during that part, and that's what causes a lot of the bad outcomes in patients with bad respiratory type issues with a lot of inflammation in the lungs. So if you control that with some of these immunosuppressive drugs, that might be helpful, and there's a little bit of data suggesting that. One of the big drugs that's being looked at a lot, and there were some early studies suggesting this, was IL-6. IL-6 is made by a lot of different immune cells, and it has a lot of effects on a lot of immune cells. IL-6 levels are really high in patients with COVID, and so drugs that reduce that IL-6 levels are being studied, and they appear to, at least, again, in not randomized trials, have a big effect. Those randomized trials are underway, and so we'll learn more about that. But what are some of the other things that we can look at? We can look at steroids and other things like that. Before that, I'll mention that IL-6, for example, here has an effect on B cells. There are diseases where patients don't have any B cells. We got to remember that with rituximab and ocrelizumab, that patients don't have a lot of times B cells in their blood, but they still have B cells in lymph nodes, around the brain, and other areas a little bit more protected from the drug itself. These patients have absolutely no B cells in their lymph nodes, bone marrow, nowhere. They just have a genetic issue where they could not make any B cells. And in these patients, we can see that they were able to recover from COVID-19, and this is a case series of 2 patients. So again, just not having B cells appears to be okay as far as being able to fight off this infection. Let me talk a little bit about kind of the reopening of clinics. So this hasn't changed too much since last time we touched base. In April, end of April, we started allowing patients back into the clinic. We're starting to get into sort of a new normal now. About 50% of MS visits are happening via telehealth now, and I expect that we will probably stay around 25%, continuing for long-term to be telehealth. You know, if I had my druthers, I would probably say new visits are probably better done face-to-face. Return visits with new symptoms, concerns for relapses are maybe done better face-to-face. But a lot of times if there's travel issues, concerns about COVID and kind of coming people into the hospital, if they're okay being at home, I think those are still visits that can still be done via telehealth. So those are not absolutes. I think we can still do some of those visits via telehealth. If you're coming in, though, just make it as safe as possible. Bring your own masks. Bring in records just to make the appointment as efficient as possible. The hospital is about as clean and as empty as I have ever seen it, so I think the hospitals are really safe. You know, as far as infections, everything gets wiped down a lot, all the doorknobs, numbers of patients in the elevators are being limited, things like that. So if we need to do a face-to-face encounter, I'm happy to keep doing that. Let's talk a little bit about testing real quick. So there's 2 types of testing. There's the PCR testing. I've gone through a lot of this stuff. This hasn't really changed. We have a ton of ability to do this testing. This is looking for active infection. It looks for the RNA of the virus. This is an RNA virus. It converts the RNA into a DNA, and then it looks at it using basically PCR. So that conversion makes it an RT-PCR. And then the machine is able to see if you have the virus or not. We have drive-up stations now, including Highlands Ranch, so even more locations than what's listed here, where we can do this PCR testing. So again, this measures acute infection. We have serology testing, which measures whether you've been infected in the past. This takes about 2 to 3 weeks to become positive. So if you're having symptoms now, this is not the test to be done. This is a blood test. Antibodies come in different ways. They come in acute antibodies, which you make at any given time, which is IgM, and then this converts over to IgG. The tests are available now through most centers, including the university, our IgG test. This is an interesting question. The test that we have now at the university is really good. It's very sensitive. It's very specific. Both are in the 99+%. And so the question, though, is how useful is it to have antibodies? And I think I've seen one question come up and say, hey, I had COVID. Am I safe from COVID, or can I get it again? And the answer is simply, we just don't know. What appears to be the case with other coronaviruses is that once you have the infection and you can mount antibodies to it, that you are likely to be protected for some period of time, but it's not for very long. It may be a year, maybe a couple of years, and then you might need to get another, another infection or something like that to kind of help boost up your immunity, or preferably we can do that with vaccines to do that. So just having the antibodies doesn't tell you that you're protected, although it probably suggests that that might be the case. Let's talk about vaccines for a while. So vaccines come in many different flavors. You have anywhere from taking parts of the protein itself and kind of making them in the lab and injecting them, to taking the whole virus, killing it, and injecting it, to something called live attenuated, where they make the virus weaker. So it can still infect you, but just a little bit, doesn't cause a lot of disease normally. But that's the vaccine. That's a bit of a concern with patients on some of our MS drugs. We try and avoid those types of vaccines as much as we can. At this point, live attenuated vaccines are kind of becoming less and less common. The old shingles vaccine was one of these. There's still the new shingles vaccine is an inactivated vaccine, so it's safer to do, but the old one we try and stay away from. What's the good news around that for our MS patients? Well, live attenuated vaccines on the bottom row are the ones that take the longest to get developed. The fastest ones to get developed are the ones that make things in the lab, and then you can kind of mass produce them and test them. They require a little bit less testing, because they're a little bit safer. And so that's likely what's going to come out first, at least. The other thing for the live attenuated is you got to grow the virus. And so if you are growing a virus that has to be done very carefully, that gets really expensive really fast to kind of do the manufacturing plans to do that. So I don't think that we will see those types of vaccines. I think it would be safe. How effective are vaccines? Well, there is a vaccination study done with ocrelizumab. It was called the Veloci study. It was 102 patients. This got reported a couple years ago on at least some of the patients. And, patients got looked at in a number of groups and things like this. But for example, I think, let's take for example, if you go under group A2 and look at influenza, you will see that under normal circumstances in 2015 to 2016, that the vaccine overall was 80% effective. But in patients with ocrelizumab, that number was only 55.6%. When you look at the next year, the vaccine was a lot better, and 97% of patients in placebo developed a good immunity to the flu. And these are flu A, not flu B, so that makes it always a little bit more complicated as well. Because sometimes you might say, hey, I got vaccinated for flu, but it didn't work on me. Well, that's one reason sometimes. But that got reduced to 75% in 2016 to 17 with ocrelizumab. So it's not that the vaccines aren't effective in patients with these drugs. It just looks like they might be a little bit less effective than otherwise. And remember, these are kind of lab-tested ability to mount an immune system via the vaccination. So it brings up the notion of some patients, or more patients maybe, might be immune to the influenza virus than 75% in that last year. But it gives us a sense, at least, that, comparing apples to apples, that, yeah, overall maybe not as effective on some of these things. Again, you have to weigh the benefits of being on those drugs for MS, and this doesn't look at whether we're not sure how effective the vaccine might be for the coronavirus. If you take it from 100% down to 75%, 75% allows you for herd immunity. If you can protect almost everybody, then you're in pretty good shape. So you don't necessarily need to be 100% to stop the spread of the virus. And as long as it's safe to do the vaccine with like a dead vaccine, then I would still recommend patients getting vaccinated, even if you're on these medicines. All right, so what are some of the treatments available out there? So these have made the news. I'm going to go through these pretty quick. Remdesivir is actually a drug that was developed for Ebola. That step of going from RNA to DNA, there's an enzyme that does that, and remdesivir inhibits that. It looks like there's an effect. So as far as proportion of patients that recovered, you can see that patients overall tended to do pretty well as far as getting recovered within just a month. Remdesivir, so let's keep it in mind, right? This is not a miracle drug. It helped a little bit. If we can save an extra 5 or 10%, I think it's worth it. It's going to come with a hefty price tag. We're looking at about $3,000 to complete a course. So not maybe necessarily a cheap option. It's kind of a shame since the U.S. taxpayers paid for most of the clinical trials for COVID-19 testing. So we'll have to kind of see where things kind of come out. I did hear something where the U.S. is going to get pretty much all the remdesivir for 3 months after it gets approved. That's a rumor, so I didn't put that in here. We'll have to see sort of what comes out from that. The recovery trial looked at dexamethasone. Dexamethasone is a steroid that is used for a lot of different things. We don't tend to use it a lot for MS relapses, but we could. Medrol Dospax is kind of a low version of this. If you look at the graphs on the left, you can see that the mortality rate dropped a little bit. And if we looked at patients who were requiring mechanical intubation, those curves really separated, had a much bigger effect in these kind of patients, meaning steroids in patients that had more severe disease appeared to be more beneficial. But again, you don't want to have severe disease because if you were in that group A of all patients, your mortality rate was still lower than what we could see in the graphs on table D. So if we need to, and if you're in that shape, they think dexamethasone, which is relatively cheap, might be a useful adjunct, add-on treatment to everything else that people are doing. So with that in mind, COVID-19 cases are starting to pick up. I think we need to be very careful. Pretty much all our surrounding states are having a big issue with this, a little bit less of an issue in Colorado. Social separation was effective. I think we're needing to reconsider. I think we're moving appropriately in our state. Our governor, for example, shut down nightclubs and drinking establishments. So I think we're learning from our mistakes and closing down maybe some of the higher risk type things. And so we need to kind of see where we end up with that. So let's proceed with caution. I think the biggest thing from my end is we see a lot of people with a lot of mental health type stuff, a lot of depression, anxiety around COVID. So we do want people to start leaving the house. We want them to exercise, to eat right, be well, not get cabin fever, but just doing it safely. So what does that mean? That means wearing your mask, washing your hands, doing those kinds of things. If you got to go to the hairdresser, go to the hairdresser. But just be safe about it and think about what you're touching. Try to avoid touching door handles and then picking your nose or things like that, where then it's just kind of a direct route to get the virus into you. And I think that that's where the masks probably are even the most helpful. Hospitals are safe, so we're happy to see you. I think things are going well. I think we're proceeding with infusions as we did before. We're pushing out some routine MRIs is still needed and trying to get closer to kind of farther time points. But let's kind of think about that a little bit. And then other than that, let's answer some questions. Let me see. It looks like we're getting shut down here a little bit, but my next slide was basically saying that was the end of it, and what are the questions?
Excellent. Thank you, Dr. Alvarez. Just a reminder, we're unable to give specific medical advice out during this webinar. If you have questions regarding your specific treatment plan, please discuss those with your neurologist. I would also like to encourage everyone to check out the COVID-19 education page on mscenter.org. We've got our previous webinars with COVID information, lifestyle resource webinars on mental health, leisure, the importance of staying active, telehealth tips, and a fun resource guide with 100+ links on it about various COVID things. As we go through these questions, I am going to be grouping similar questions together because we are running short on time. For the first set, Dr. Alvarez, I really appreciate that you discussed the complexity of the social distancing situation. That was a large number of our questions. So if it's okay with you, I'd like to try to summarize a little and then see if you have anything to add.
Perfect.
So the factors affecting your personal risk level have more to do with age and the other comorbidities that have been discussed today rather than MS specifically. Once you assess your personal risk level based on those things, you will also want to consider the specific situation that you're wanting to participate in. Is it going shopping, seeing friends, getting a haircut? You'll want to make sure that the person you'll be interacting with has been keeping to the same level of precaution and social distancing that you have or that you're comfortable with. For instance, if you have diabetes and MS, you will want to take more precautions than someone who has no other comorbidities. And you would want to be more aware when you are out that you are being safe and so are the people around you. And then this risk analysis would also apply to your working situation. Does that summarize it?
That's a perfect summary. Perfect.
Awesome. I've listened to a few of these. I did want to ask a couple specific questions about MS treatment and the hospital. We've had a couple of different questions wondering if how safe it is to go for infusions. Are people with COVID in the same areas that you're getting your infusion? And then also just general hospital, is there still only one entrance for outpatient appointments? And kind of is there, should we be allowing more time to get our temperatures checked and standing in line? What does the hospital look like?
Yeah, so some of these things I think have changed a little bit since probably we did last time. So the infusion centers is a great point. The infusion centers are very safe. In the hospital, they started to allow one visitor to come in, except in the infusion center. Why is that? Because again, it's a little bit of a tighter space, and to allow those 6 feet plus of separation between patients, the chairs are 6 feet apart from each other. But during that time, to kind of reduce sort of moving air and other things like that, they've eliminated the visitor policy for that, and so no visitors unless you need a visitor for communication, help translate or things like that. Then there's a few exceptions around that I think is a very appropriate next step. So I think that's very safe. And the hospital has started checking temperatures finally. We were really nervous about this initially, given our patients that were immunosuppressed, and so we were doing this in our clinic. This got changed, and as of, I think, 2 weeks ago, started happening, maybe it was only last week, started happening at the entrance of the hospital. So we're starting to do that, and then there's a mostly requirement of everybody wearing a mask, so all patients are highly encouraged to wear a mask. All visitors that come with that patient must wear a mask. I would pretty much make it a mandatory that you must wear a mask in the hospital. If you don't have one, they will be provided to you, those kinds of things. So the hospital is surprisingly empty. There were always lines to get on the elevators and things like this. I think cutting down on the number of visitors has really reduced the number of people kind of walk in the hallways and things like this. The elevators are very efficient to get people in. I've not yet seen a line waiting for an elevator, which is something I never thought I would see. It's impressive. 90%. We're still seeing about 90% of all patients that we did pre-COVID in person. Again, the number I said about 50%, that's specifically the MS group and most of neurology. But as an outpatient center, as a clinic building, the number of visits being done face-to-face is over 90%. A lot of that surgery cases and things like this where it's hard to do that via tele. So cutting down on visitors, I think, has opened that up a fair amount. The cafeteria is not open, so that's kind of the biggest bummer. The coffee shops and other places around that are open, so it looks a little bit different, but I think we can do everything that we need to do now in the clinics really well.
What are some target white blood cell and lymphocyte numbers to be aware of with the different DMTs?
Yeah, so we've not changed our targets and based on COVID, and I think it's only emphasized that we need to look at those numbers carefully. And I'll be a little bit hesitant because the numbers vary by different drugs. So the lymphocyte counts in Gilenya, we're okay going all the way down, for example, to 0.2. For Tecfidera, numbers still 0.5. So different drugs are a little bit different. We monitor still antibody levels, the IgG levels, and a lot of our B-cell directed therapies and things like that. So we are still looking at that very carefully. We were kind of holding back a little bit on labs to reduce people coming into labs and exposing them to more people. I think that we feel that the hospital is very safe and with being able to do labs and clinic for people that come in or sending people to any of the labs is very easy and easy to do. Our lab even has not just for the COVID nasal swab, but just for even blood work. You can stick out your arm from your car and they'll draw it from you at the drive-up station. So we're really kind of getting in a position that we feel comfortable to be able to do all that testing over the last month or so.
Great. Do you know what BMI the studies used to define obesity?
The BMI was mostly around 30 for obesity.
And then can you talk a little bit about our local experience with COVID at Anschutz?
Yeah, so we continue to get patients who are testing positive for COVID. I had one this morning and another one yesterday, so I mean the number of cases is coming up. Most of these patients are doing really well. We did have one death locally who was on Ocrevus. A little bit of an unusual case in the sense that they were younger than what you would expect. They were in their low 40s. As we talked about, the average person who is dying with MS from COVID is, mid to high 60s. It was 69 as of last week, so there must have been somebody kind of younger that brought that number down quite a bit. So we do see it in younger patients, but for the most part, our pattern of kind of how well patients are doing and recovering fits with a lot of the databases that we're presenting. And we're contributing all our data to the U.S., to the National MS Society registry, and it looks very similar to that. Because we use so many B-cell directed therapies, a lot of our patients are on B-cell drugs, and again, recovering fairly well from it.
Speaking of the B-cell therapies, if somebody had COVID in the beginning and maybe still has some lingering symptoms, would Ocrevus affect how they might be able to continue fighting off that virus at all?
Yeah, so that's, I think that's the theoretical around, potentially with these medicines that somebody may have COVID symptoms a little bit longer, those kinds of things. That gets really hard to measure with a lot of these retrospective type cases just because the data sometimes isn't there to kind of really get a good sense of that. I think the important part that we've always done is making sure that when you are getting infused with these medicines that you are at your tip-top shape. We want to make sure, and we've always asked and had the nurses at the infusion centers ask that you don't have any fevers, that you don't have any cold type symptoms or things like that. If there's concerns for any acute infection, we don't want you infusing. Now, if you're kind of getting, a month or two out from your COVID, you still have some sniffles and things like this. Some of that is just kind of the recovery that happens. You've cleared the virus, but it takes some time for the repair of the lung tissue and things like that to happen. And so as long as, that's the case, that's kind of the point sometimes where we might want to do a COVID test so that we can eliminate the chance that you might spread it to other people coming into the hospital to do that.
And you've talked in great length both today and at our last webinar about kind of our treatment thoughts, resuming normal treatments for like the infusions and things. But I just wanted to kind of reiterate that there are no suggestions from you guys that people would switch DMTs specifically for COVID.
At this point, that's correct. We're not doing that. I think it's making us think extra hard about getting the right risk benefit profile for patients, meaning I think sometimes it's very easy to kind of start a patient on a treatment and then kind of let it be, and 5 years later we go, the chances of a relapse in you is really small. The risk maybe went up because now you're older, the disability kind of went up, and maybe we should rethink what treatment you're on. So I think it's a little bit easier to get on autopilot and think about some of those things. I think COVID's kind of pushing us to kind of say, do we really want to keep this person on treatment? Is there still some benefit from that treatment? Those kinds of things. And so I think it's really highlighting that you need to talk to your provider and kind of really reassess whether or not to stay on that treatment or not. And so I think as we learn about this, the risks have kind of come down. And so before we knew that, we were starting to kind of consider maybe a little bit more of some of the switches and things like that. I think as time goes by, we're starting to kind of leave things be a little bit more.
Excellent. And we have gone over our time, but I will wrap it up with just one final question, kind of a combination of two questions. What would you say is the best action that a person with MS can do to successfully either survive coronavirus or kind of be at their best in order to avoid getting it in the first place?
Yeah, so I think this is the point around wellness, and sounds easy, but as we all know, it's a little bit harder to do, right? So if you're not obese and your diabetes is well controlled, or you're strong and not deconditioned, things like that, you're going to do much better with any sort of infection, not just with COVID. So exercise, eat right, be healthy, meditate if you're under stress, things like that, become really important to kind of try and get to your tip-top position before any of this stuff could potentially kind of come out and happen. So I think to stress that point becomes really important. I think the second point is a little bit as to what can I do to reduce the chances as well from kind of other protective measures. So we talk a lot about masks and protecting others and maybe not doing much for us. I still think they protect us. And the reason for that is when I wear my mask, I can tell you how much I touch my face. I touch my face a lot. It's a habit of mine, maybe not necessarily picking my nose, but just scratching my nose and kind of playing with my goatee or whatever. And so I think when you're wearing a mask, it helps you prevent doing some of those things because you notice yourself doing it. So when you touch that door handle, when you shake somebody's hand, do those kinds of things, you start to go, oh yeah, and maybe I don't want to scratch my face with it. So I think wearing masks for that perspective is very helpful. That starts to bring out thinking about what you're touching, where you're at, those kinds of things. I think that, going to the grocery store is important and you need to do it. You need to get out and do those kinds of things. Those are the kind of situations where when you get home, wash your hands a lot and then change clothes. For people that are working and having to see a lot of people at work and those kinds of things, hand sanitizer, washing your hands, when you get home, change out. If you have the possibility of requiring in a business that your customers wear masks, do so. It's your right to do that. I think that will help you as well as it helps other people as much as you can. If you're in high-risk, professions, touching base with your healthcare provider around, is it safe for me to do this or not? More than likely, we're going to say it's safe as long as you're following good precautions of wearing masks, washing your hands. If you need to be wearing more PPE, such as face shields or things like that, we just want to make sure that you have that kind of access to that type of equipment. Hopefully that answered that question, Kelsey.
Absolutely. That was a perfect wrap-up. Thank you so much for your generous time today, and thank everyone for submitting questions and tuning in. Make sure that you're on our email list to hear about the next one. Thanks.
All right. Sounds good. Thanks, everybody, for listening in. I really appreciate everybody's time. Thanks, and bye-bye.